So for just a reminder to all participants, this webinar will be recorded and can be accessed online after this webinar. So for our next speaker is Dr. Goh Liuh Ling, who will be going through the application of SS656 in a clinical diagnostics setting. So Dr. Goh is the Senior Principal Scientific Officer of Diagnostic Hospital, and she supports the personalized medicine services and oversees the molecular diagnostics laboratory. She has a strong interest in liquid biopsy research and its clinical applications. Today, she will provide insights into the validation of mRNA-based assays for clinical use. So let us welcome Dr. Goh, please.
Thank you for the introduction. Before I start, I'd just like to share briefly about our laboratory and the type of work we conducted. The TTSH Molecular Diagnostic Lab is set up in 2014 to support the research activities and translational projects for our institution. In 2017, the lab is CAP accredited to provide clinical testing for our patients. Now, most of our molecular tests are for disease management, where we evaluate biomarkers or genetic variations for diagnosis, targeted therapy, and monitoring. There has also been a lot of interest in early disease detection. In fact, we are seeing this paradigm shift from sick care to healthcare. And we think early disease detection is getting more important, and the rationale is obvious because if we can detect the disease early, the patients tend to have better prognosis and they can seek treatment earlier, and that would also be translated to the reduction of healthcare costs and burden. Last year, we launched the blood-based microRNA-based screening assay, which you heard about from Lihan earlier. It's called GastroClear. Now, this is a screening test for gastric cancer. What we did is to measure the expression of multiple microRNAs. The results of the individual microRNA will be combined in an algorithm to calculate a risk score. So for patients who are tested as high risk, then they will be recommended to go for gastroscopy if it's also clinically indicated. This slide shows you the typical processes that we took before a test is implemented for clinical use. We have to evaluate its clinical utility. You have to check whether there's a business case for it. Is it scientifically sound? What are the clinical performance of the assays? We also have to consider the laboratory workflow for sample receipt, pre-processing, all the way to reporting. It's important to validate the test to ensure that it is accurate, it's robust and reproducible. You also have to think about your quality assurance program, and what I mean here is proficiency testing. If the lab is not available in the proficiency testing menu, what we can do is to perform a specimen exchange with another laboratory. So everything is well and good. You're ready to share the test with your clinician and work out your test request route. Although these are pretty standard procedures in most of the molecular laboratory, there are special considerations when one works with microRNA, especially the pre-processing steps. And I have highlighted the relevant sections in the S656 standard in blue over here. So what I'm going to do in this presentation is to share our experience in validating GastroClear for clinical use and highlight some of the important considerations. As mentioned earlier, the first step is to evaluate the clinical utility. So indeed, gastric cancer is clinically important. It has a low 5-year survival rate, often because it was detected late. So there's a clinical need for it. We talk to the relevant stakeholders, like our colleagues from the Department of the health screening clinic, to get their professional opinions as well as their buy-in. It's important to evaluate the scientific validity of the test. So what we did is to conduct a literature search to ensure that there's a clear link between the microRNA biomarkers and the clinical condition. It is important to evaluate the clinical performance of the test. These are important because the clinician are going to ask you the values. So it's important to have this ready before you even talk to them. Ideally is to evaluate the data from actual clinical use, but because this GastroClear is rather new, so there wasn't much clinical experience data, but there are proof of concept studies conducted that we can evaluate. So for an effective screening test, we will be looking at its sensitivity, specificity, positive predictive value, and negative predictive values. So before I show some of the actual data, I would just like to go through the concept and the terminology here. So let's first look at sensitivity and specificity. These values can be calculated from a standard 2x2 table, where the test results are compared to the results of the disease or the gold standard. In sensitivity, we are really looking at the fraction of those tested positive in all with disease. And for specificity, we'll be looking at all those tested negative in people without disease. So these values will reflect the accuracy of the test. So for a screening test, we are really looking for high detection rate and low false positive rate. In other words, we want something like, say, 100% sensitivity and 100% specificity. But in real life, that's not going to be the case, because we are going to see some false positive and false negative, as shown in the plot here. And these values are determined by the cutoff chosen. Now, just to share with you the concept of the cutoff, if I'm going to shift the cutoff a little bit to the left, what you see is that the sensitivity will increase. We're going to pick up everyone with the disease. However, the specificity will decrease because some of those without the disease are going to be tested positive. So how do we determine the optimum cutoff? We can actually use the ROC curve to help us. In this plot, the true positive rate or sensitivity is plotted against the false positive rate for different cutoff points, and the best cutoff point will give you the highest true positive rate together with the lowest false positive rate. All right. Besides that, we also look at the area under the curve. That will be used to measure how good the test is in a given clinical situation. So in the clinical context, anything more than 0.9 will be considered very good. Between 0.7 to 0.9 would be moderate. 0.5 to 0.69 will be considered low, and anything below 0.5 is not acceptable. So on this plot, it's very obvious that A has a better performance than B. And anything below the dotted line should not be used for clinical purposes. Let's look at the actual data from our industrial partners. They performed a prospective cohort of symptomatic patients. And when I first look at the number size, I think it's reasonable, 4,566. The AUC value is 0.85, so it's considered moderately good. And it performs better than other blood-based biomarkers such as the pexinogen and Helicobacter pylori infection. We look at the sensitivity and the specificity. It's about 44% and 93.94% respectively when the cutoff is at 50. The performance characteristic is better in asymptomatic high-risk population and newly diagnosed patients. They performed another validation study in a local cohort. The sensitivity has increased to 81% and subsequently verified in another cohort is 82%. So we are rather pleased with the performance characteristics. I'd like to share a little bit on predictive values. A lot of times they are not in the literature, but these are important because it will help the clinician to discuss the results with the patient. The positive predictive value is defined as how likely one tested positive has the disease. And the negative predictive value is defined as how likely one tested negative does not have the disease. And these values are affected by sensitivity, specificity, as well as the prevalence of the condition in the target population. I showed this earlier just to show you that the PPV and MPV can also be calculated in the same 2x2 table. It's just that this time we will consider the values across the rows instead of down the columns. So sensitivity and specificity will reflect the accuracy of the test, but the predicted values is related to the likelihood of the condition. Just to illustrate to you the effects of prevalence on the predictive values, let's say you have an assay with very high sensitivity and specificity of 90%. Now, in a given population of 2,000, when the prevalence is high, you will have a high PPV and MPV values of 90%, which are actually very close, or in fact exactly the same as our sensitivity and specificity. However, when the prevalence is low, you'll notice that the PPV decreased to 8.3% and the MPV increased slightly to 99.9%. So these are the values from the same cohort study shared earlier. The PPV is 16.98% and the MPV is 98.35%. In other words, for a patient or an individual tested a negative, then most likely the person has a very low risk for gastric cancer. I'm going to move on to workflow. Li Han showed earlier that there are 4 major steps in GastroClear. The pre-processing step, where we spin the blood tubes, and then one needs to isolate the microRNA from the supernatant, perform a cDNA, followed by amplification and fluorescent detection. Now, there are several considerations in the workflow, especially for sample processing, because of the stringent requirement to spin the blood tube within a certain time frame. So one has to really work out the logistic with the clinics as well as external labs. But once the blood tube has been spun, they can then be stored at minus 80 degrees freezer, if not at least a minus 20 degrees freezer. So it's important to consider the resources available in the lab. In this case, we don't have much problem with the equipment because we have the thermocyclo, the real-time PCR instrument, and our people need minimum training in performing the test because they're already familiar with RNA work as well as a liquid biopsy, although they do need some training in terms of result interpretation, troubleshooting, and handling inquiries. We have to plan long-term whether we can scale up the test, as because it's working on the 384 well, so it will be good, and especially when the load is high, to have a liquid handler to help. The turnaround time is determined or guided by the urgency of the clinical management. So if we have to churn out the results within a very short time frame, we have to see how it will affect other workflows in our laboratory. It's important to have the relevant controls, not only for the validation, but also for subsequent quality assurance program. We have to think about how we can automate the analysis, what goes inside our report, can we standardize it, and how we can integrate it with our LIMS system. I'll move on to analytical validation. This is the process prior to implementation to demonstrate that the test delivers reliable results for the intended application. Now, typically, we will have to decide on the number of specimens to be tested, what are the relevant specimen type, in this case would be blood samples. We have to determine the accuracy, the precision, the limit of detection, the reportable range. So we have to set the criteria and make sure that we pass all of this. Because this is an CE-IVD kit, so for some of the parameters like interference, carryover, assay stability, and cross-reactivity, we can obtain the information from the manufacturer and state in our validation report. Just to share with you some of the data during our validation of GastroClear. Accuracy refers to the degree to which a result conforms to the correct value or a standard. So we run 50 clinical samples in parallel with another laboratory and check for concordance. So we find that 92% of the samples are in concordance, and for those few that are discordant, it's because they're very near the cutoff at 50. Precision refers to the degree to which repeated test results on the same sample agree. So we perform both intra-assay as well as inter-assay precision. For intra-assay precision, we basically test the samples in duplicates within the same run. And for inter-assay precision, we have the same set of samples run by different technologies on different days. So 3 spike-in samples were used for this, and we passed the criteria. Now, limit of detection refers to the lowest analyte concentration, allowing consistent differentiation from the limit of blank. In this case, it's water. So what we did is to perform a zero dilution using synthetic microRNA to obtain the lowest detectable concentration indicated by the manufacturer. So this our dilution can also be used to verify your reportable range. Back to LOD, the passing criteria will be the percentage of all measurements with a CT value less than that of the LOB must be less than 85%, must be more than 85%. And the CT value standard deviation must be less than 0.5. And as you can see in the table, we passed the criteria. So this is my last slide. I'll share a little bit on how we should evaluate the clinical utility of the test and what are some of the special consideration as well as the validation procedure. The standard will provide more information, especially on the collection, handling and isolation of microRNA, not just for blood samples, but also for other specimen types like tissues or other biological fluids. There's also a section on the guidelines for reporting, which will be helpful for the clinical lab. Thank you.
So thank you, Dr. Goh Liuh Ling.